You're listening to Treating Blood Cancers, the LLS podcast series for professionals. We will be joined by cancer experts to discuss blood cancer diagnosis, treatment, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the LLS podcast series for professionals. I'm Dr. Ken Miller. I'm a medical oncologist, a hematologist, and an LLS volunteer. And I want to thank all of you so much for joining us on this episode. Today, we'll be discussing myeloproliferative neoplasms, MPNs, including current and emerging therapies, strategies for managing side effects, and education and support resources for patients. We're delighted to be joined by Dr. Aaron Gerds, who's an associate professor of medicine at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University School of Medicine, and the medical director of the Case Comprehensive Cancer Center Clinical Research Office in Cleveland, Ohio. Aaron, thanks for joining us.
Thank you so much for inviting me. It's a delight to be with you today.
So I have to say, I've been excited about talking with you. Besides talking about the topic, I've got two challenging cases that are relevant to this week. So I hope they will be for other people too. I would love to get your overview of the myeloproliferative disorders. And I have to say, one of the things I've been interested in, obviously there are molecular correlates of this. And how is it that for some patient it heads in one direction or another direction or a third?
Well, Ken, that's a fantastic set of questions there. And really, one of the most interesting parts of MPNs in general, or myeloproliferative neoplasms, is the fact that you do have kind of a central pathobiology that can result in different diseases. And it's just a fascinating proposition. And it goes way back in history, if you will. Myeloproliferative neoplasms were first described at the turn of the 19th century. And then in 1951, William Demeshek, a former ASH president, first editor of the journal Blood, postulated in a editorial, said, you know what? ET, PV, myelofibrosis, they're all very similar. I bet you that there is some sort of common pathobiology amongst these diseases. But of course, it wasn't until 2004 where 4 labs independently discovered the recurrent mutations in MPNs, this JAK2, V6, and 7F mutation in particular. And that really kind of changed the whole field, because then we started saying, okay, well, we know why these somewhat different diseases all have similar features because of this common pathobiology. And it gave us something to chase in terms of a target for treatment. So it was really a kind of a watershed moment in the field. But why does someone who has a JAK2, V617F mutation develop ET, and then the next person develops PV, and the next person develops myelofibrosis? We don't really know. There's been some interesting studies trying to answer those questions. Last year, a bit of data came out looking at really what I would say are, in essence, polymorphisms that have a lot to do with platelet biology, or platelet production, in fact. And this set of like 30 some odd polymorphisms certain polymorphisms clusters in people who have normally high platelets. They'll be in the normal range, but they'll be like 350, if you will. And if those sets of polymorphisms are present in the same person with a JAK2 mutation, that person then seems to be more likely to develop ET. But if those polymorphisms aren't present, then perhaps it goes on to be PV or myelofibrosis.
Got it.
We also think that there's something with PV in particular, something about male versus female, because it's a 2-to-1 ratio. Whether that's, some postulate that just masking, women mask PV more often during their earlier adulthood up until menopause.
Mm-hmm.
But really, there does seem to be that differential. So there's been a lot looking at testosterone receptor, and how does that play in with the development of PV in particular. But beyond that, we really don't know. It's pretty remarkable that a unique pathobiology leads to 3 different yet related diseases.
Yeah, interesting. I wanted to ask you also about, again, from the generalist point of view, we think of 3 mutations, JAK2, CALR, MPL. Just in your experience, how are those 3 different from each other, both in terms of the biology and in terms of the presentation?
Wow, this is a fantastic discussion already.
Good.
Really, because we talk about the morphology, we talk about PV, ET, myelofibrosis, and these morphologic, what does it look like under the microscope type categories. But really where our thinking is going, and what we're starting to realize, is that these are different diseases based on their, again, driver mutation. We know that there is distinct behavioral differences between a calreticulin mutated MPN versus a JAK2 MPN. MPL is a little bit harder to grasp since it's a smaller subset of the population. We only 5-ish, 10-ish% of patients will have an MPL mutation. So it's a small subset, but calreticulin accounts for a quarter to a third of patients with ET and myelofibrosis. So it's a pretty big chunk there, and we can start to draw differences. Calreticulin mutated disease, whether we're talking ET or myelofibrosis, tends to have a better survival, particularly type 1 calreticulin mutations. It tends to have higher platelet counts relative to JAK2 mutations, and it tends to be more resistant to hydroxyurea relative to JAK2 disease. And I think the reason that this is starting to evolve is because we can get this genomic information relatively quickly and cheaply and multiple times throughout a patient's disease course. But also, we're trying to think beyond just the category of MPN, right? So there are pre-existing conditions like CHIP, or clonal hematopoiesis of indeterminate potential, of which the most common mutation, the fifth most common mutation, is JAK2 V617F, right? And then there's this also entity in between where we know it's kind of called clonal hematopoiesis with megakaryocytic dyspoiesis and thrombocytosis. But it's basically like a pre-MPN state where there's a JAK-STAT driver mutation. The megakaryocytes are a little funny looking, but not enough to call it an MPN. And there's some slightly elevated platelet counts in an individual. So it's not an MPN yet, but it's clearly this pre-MPN state. And so as we expand our view out, we realize that this disease really isn't ET-PV and myelofibrosis, but it's JAK2 MPN, calreticulin MPN, MPL MPN,
Interesting.
and the others.
Yeah, I think it's a really good intro to a couple of clinical questions. So now, this week, I'm seeing a woman who is late 60s, has a platelet count of about 1.4 million. It varies 1.2, 1.3. The other blood counts are good. So I did a JAK2, it was negative, and she's got the CALR. And a couple of things I'm wondering. One is really, how did these genes, how does CALR, JAK2 for that matter, actually drive hematopoiesis? But even more importantly, how do you make decisions? Let's say this patient, how do you make decisions on who to treat?
That's a great question. So CALR, JAK2, and MPL all overdrive the JAK-STAT pathway. JAK-STAT pathway is the key signaling pathway, if you will, for how our growth factors or cytokine growth factors drive blood production in the bone marrow. Erythropoietin being the most well-known, I think, of all those, or GCSF or thrombopoietin, right? So each of those molecules, those cytokines, hit their receptor, and then activate the JAK-STAT pathway to lead to proliferation. So when JAK2 becomes mutated, the JAK2 can then dimerize with any other JAK molecule or itself, signaling the pathway independent of the growth factor. So you could have an EPO level of 0 or 1 billion, and the red cells will keep coming out, right? They'll keep being produced. And MPL encodes for the thrombopoietin receptor. So that makes sense. That's mutated, it's constitutively activated, and thus it's activating the same downstream pathway.
Yes.
Calreticulin is the weirdo in the group. So calreticulin, if we can remember back to biochemistry from like first year med school, it's a chaperone protein from the endoplasmic reticulum. So when your NER is developing a protein and finishing it, calreticulin is there to kind of help chaperone it through the ER. But when it becomes mutated in this fashion, it gets stuck on TPO receptor, on the thrombopoietin receptor. So it gets stuck on the thrombopoietin receptor, and then the thrombopoietin receptor is put out to the cell surface and it's activated. It's constitutively activated because that calreticulin protein stuck in it, activating it, independent of cytokine. So that is really important for two reasons. One, well, it's just kind of cool to think about this, but
it is.
More
yes.
importantly, since it is outside the cell, we can target it with things. And so if it's outside the cell, we can design a monoclonal antibody to disrupt that interaction between the mutant calreticulin protein and the TPO receptor. We can design bispecific antibodies that cue into that, or CAR T cells or vaccine therapies. And so this is really kind of a hot area of research right now in therapeutics for MPNs, is calreticulin mutation specific therapies that are antibodies, immunotherapies, and the like. Very hot area of interest. And calreticulin is also important in determining disease risk. I mentioned that we now think about disease as JAK2 or calreticulin mutated or otherwise. And we know that not only do calreticulin mutated disease, those patients tend to live longer, they have a much lower clot risk. In fact, in an ET patient like you have in their 60s with a high platelet count, I'm not surprised that it's a calreticulin mutation driving that, given the platelets were so high. But it also does factor into our risk. So normally in the old risk stratification model for thrombosis risk, we'd say this person's high risk based on their age. But in fact, with the revised IPSET thrombosis score, they're intermediate risk. The risk isn't as high as what we originally would think because of the calreticulin mutation. So a person who is over the age of 60, who does not have a JAK2 mutation and does not have a history of thrombosis would be intermediate risk. And if we look at things like the NCCN guidelines, they recommend aspirin potentially and keeping an eye on things. You don't necessarily always have to jump in with cytoreduction in someone like this.
Got it.
Now, if they're symptomatic or have acquired von Willebrand's or something like that, then that's different. But in someone who's asymptomatic with a calreticulin mutation, you don't always have to bring those platelet counts down.
Which is very helpful because typically that might be the knee-jerk reaction, is to try something.
Very much so. I think that's a real issue in ET in particular. I think we overtreat it with hydroxyurea, even in young patients who have never had a clot, who have calreticulin mutations, who are the lowest risk category. Their predicted blood clot risk is about 0.5% per year. And these folks are subjected to hydroxyurea or other medications to lower their counts.
This is not a pressing clinical scenario, but I find a really interesting one. And what I want to drive at is the issue of the effects of these gene mutations and these diseases that may be subclinical. So I saw a woman who is around the same age, about 70, presented with a portal vein thrombosis. And her numbers, her H&H, were basically completely normal. Well, someone in the hospital wisely sent off a JAK2. It came back positive. So where is the defect that leads to thrombosis in someone with a normal H&H?
Oh, that's a great question. And this is not an unusual case. I hear about this all the time. A person who's otherwise has normal blood counts, have an unexplained visceral thrombosis, they check a JAK2. And this is from older data that suggests that in patients who have Budd-Chiari, who don't have an readily identifiable thrombophilic state, 30% of the time, JAK2 will be mutated in those patients. Now, you can postulate, is this some sort of masked polycythemia vera? It's hard to say. But we do also know that patients with CHIP, not a hematologic malignancy yet, but CHIP, JAK2 mutated CHIP, have a much higher risk of clot, DVTs, cardiovascular disease for sure. And so there is something about that JAK2 mutation that is driving thrombosis. We don't really know why. There's certainly some speculation about cell adhesion molecules on white blood cells being a key player in all of that. So the white blood cells have the JAK2 mutation in them as well. They're extra sticky, if you will, and can propagate thrombosis. There was a really old paper kind of showing that in patients who have JAK2 mutations, you can actually isolate endothelial cells, vascular endothelial cells that will have JAK2 mutations in them as well. So there might be something there, these JAK2 cells intercalating into endothelium. There have been other looks at cytokines and other procoagulants, but at the end of the day, nobody really knows for sure. There's not this happens and that happens and that's why these people clot. But certainly in someone who has unexplained clot, doing a JAK2 test is something that is completely warranted, and we find a lot of these patients.
I suspect that sometime in the future there will be answers, and we may all say, that's what it was. I'd like to turn some to myelofibrosis, because I have to say in my career it's the one that I've seen the least. What are some of the differences between, or are there between acute myelofibrosis and more of the chronic condition that we call an MPN?
Yeah, and so with myelofibrosis, I think as you alluded to, a spectrum of disease. There are some patients with very aggressive acute type of disease that will progress in a very short order of time. And there are other patients with disease that just kind of lulls along for decades even. And I think a lot of that goes back to what's under the hood inside of that disease, the mutations, right? So we know, again, type 1 calreticulin disease with no other mutations and intact bone marrow functioning, those patients are predicted to live a very long time. In some models, so long we can't calculate a median survival for those patients. But if you start seeing low driver mutations, JAK2 mutations, second, third, and fourth mutations in their disease, and then you start to see bone marrow dysfunction, anemia, thrombocytopenia, those people have a very aggressive disease course. And if they have good health status and their disease is under somewhat good control, you would think about transplantation for those folks. But it really is a broad spectrum of disease. Whenever you look at these kind of prognostic models, those curves are so far apart.
Yeah.
It really is impressive.
How often does it come up that you don't find one of these driver mutations? And what do you do in that scenario?
Yeah, so I would kind of have two levels of answer to that question. So if you don't find one of the three kind of classic driver mutations, you want to find some sort of clonality. I think to call it a myeloid neoplasia, if not an MPN, whether you're finding some sort of chromosomal abnormality, a mutation in another JAK-STAT driving molecule such as LNK, or even other kind of common myeloid mutations like TET2 or ASXL1. You want to see something there that's clonal. It's pretty rare not to see a clonal change at all. We're talking just a couple of percent of patients. And whenever I get that patient in front of me who has no clonality to their disease that we can detect, I'm circling back and really like doing a heavy investigation into rheumatologic disorders, checking CRP, ESR, rheumatoid factor, all that, talking to them about their joints, their skin, their eyes, because there's this entity called secondary myelofibrosis, also known as autoimmune myelofibrosis, that can occur. And the treatment is different, right? We use steroids and rituximab to treat that, kind of like you would like a rheumatoid type disease, right? As opposed to JAK inhibitors and potentially transplant. It's pretty uncommon these days not to find clonality. And again, it's to a point now where it always makes me stop and think about, is there something else going on here?
I want to dig in on myelofibrosis because, again, it's fascinating and it feels less understood in some ways. The patient who's got the more chronic spectrum of this disease, what's your approach to treatment for them?
So the approach I take for myelofibrosis is kind of a two-step process. After you see the patient, you confirm the diagnosis and you do the risk assessment, right? So if their predicted survival is less than 5 years with whatever model you use to predict survival, then you're thinking, okay, this person might be amenable to a bone marrow transplant, or more precisely, a stem cell transplant, because it's always peripheral blood with those, because that's the only thing that can potentially cure this disease. Despite all the wonderful treatments we have nowadays that are available, that is still the only thing that is potentially curative. So first things first, is this person a transplant candidate? Meaning that their disease is aggressive enough and they're otherwise healthy enough. Outside that, really the decision to do treatment is based on symptoms. The 4 drugs that are FDA approved now to treat myelofibrosis, they're all JAK inhibitors. And their strength really is shrinking spleens and improving symptom burden. It's not killing myelofibrosis cells. It's not reversing the scar tissue in the bone marrow. And so really, it's to treat symptoms and splenomegaly. So if a person who has myelofibrosis doesn't have a big spleen or is not having a lot of symptoms related to their disease, then there's not a lot of reason to really push treatment at that point. There's no evidence that early treatment in asymptomatic patients with minimal splenomegaly really get any benefit from early JAK inhibitor. Now, if someone does have palpable splenomegaly, that's symptomatic, that's different. But for very low risk patients who otherwise wouldn't know they had it, then there's no reason to jump in with a JAK inhibitor at that moment. But if a person comes in and says, hey, my spleen, I feel on their belly, their spleen's big, and I'm having night sweats, I'm losing weight, by all means, that's when I institute a JAK inhibitor. And that's independent of disease risk, really.
So interesting. So the patient with P. vera or with ET or with very early myelofibrosis, again, it sounds like treating them with a JAK inhibitor probably does not change the natural history. Is that fair to say?
Yeah, well, it does and it doesn't. So we do know from long-term data from the COMFORT studies, which was the studies that were done in myelofibrosis with ruxolitinib, that patients who are randomized to ruxolitinib lived longer than those who are randomized to placebo or best available therapy. But the curves still go to zero, right? There's no plateau in those curves. And those patients are probably living longer because they're living better. Their cytokines are lower. They're probably having fewer complications earlier on. They have better performance status and all these things. They're living longer because they're living better, not necessarily because we're lowering allele burdens or killing myelofibrosis cells or reversing scar tissue.
What are some of the differences between the JAK inhibitors? I mean, is there a way you make a choice? And how do you think through that?
Yeah. So if you line up all the JAK inhibitors and what molecules they're hitting, they all inhibit wild-type JAK2. That's the kind of common theme amongst all of them. All inhibit wild-type JAK2. Not all of them inhibit mutant JAK2, but that's okay. It's really inhibiting the wild-type JAK2 that makes the difference and treats the spleen and symptoms. Some will inhibit JAK1, which we think can lower cytokines maybe a little bit more. Some will hit other targets like FLT3, which we know is important in proliferation and may also account for some of the side effects that those patients experience. Lastly, momelotinib and pacritinib inhibit this molecule called ACVR1, also known as ALK2, which is upstream of the gene that encodes hepcidin, which is really kind of a new thing and a hot topic within the myelofibrosis world, because we know that there's anemia of inflammatory response in these patients' diseases, where their inflammation is elevated, their hepcidin levels are elevated. That hepcidin then keeps the iron inside the iron stores, making it unavailable for erythropoiesis. And that if we can lower the hepcidin levels with a drug like momelotinib or pacritinib, the iron can flow out of the iron stores, being made available for red cell production, and these patients can actually have anemia improvements. And some patients will go on to transfusion independence even with these new agents. So if we think about it as like, ruxolitinib is the classic, it's a JAK1, JAK2 inhibitor. It works well in very proliferative patients with higher counts, big spleens, lots of symptoms. We think about momelotinib in patients who are anemic, pacritinib in patients who are thrombocytopenic because of also the IRAK inhibition and the sparing of JAK1. And we think about fedratinib in kind of the second line setting in similar patients that you may use ruxolitinib, but we kind of start to position these different JAK inhibitors within the spectrum of disease.
We start patients on a JAK inhibitor. Any idea what the mechanism is for seeing less splenomegaly?
It's really lowering the cytokine levels.
Got it.
So that's the big push there. So the JAK inhibitors block the interaction of the JAK molecules as they dimerize, the active form conformations of these JAK molecules as they dimerize, thus stopping that constitutive activation, at least in wild type signaling in the JAK-STAT pathway. And that lowers ultimately cytokine levels. And as those cytokines come down, the spleen can kind of shrink because a lot of the splenic expansion in myelofibrosis in particular is due to the cytokines driving that tissue to expand and grow. Just like when someone gets mono, right? So you get mono, all those cytokines are flowing around trying to kill off the mononucleosis virus, the EBV virus. The spleen expands in response to that. And then once the virus passes, that spleen can kind of shrink back down to normal. So that's what we're really doing with the JAK inhibitors. We're lowering cytokine levels that shrink down the spleen.
It's not as much an issue of extramedullary hematopoiesis.
So EMH is prevalent in myelofibrosis and generally in more advanced disease.
Yeah.
So it may help with the EMH as well. There is some anecdotal evidence where, EMH, whether it occurs in the spleen, the liver, the mental fat, lung tissue, or breast tissue, we can kind of see that shrink somewhat on JAK inhibitors. But it's really just kind of the general reduction in spleen volume due to reduction in the number of cells in that spleen.
So what's the latest? It sounds like some significant improvement in the understanding of the biology. So what are the things you're excited about and involved in?
So where are we now with the treatment of MPNs? Well, I think we have 4 JAK inhibitors that are FDA approved to treat myelofibrosis. One of them also has a label indication for polycythemia vera, ruxolitinib, that is. We also have ropeg interferon, which is approved to treat polycythemia vera. In ET, we're still looking for better and newer treatments. The only drug that is FDA approved for ET right now is anagrelide, which is probably our least favorite option altogether. But I think there's a lot of opportunity going forward for these diseases. And I think there are a couple of themes. One, for myelofibrosis, combination therapy is definitely the thing that everyone's got interest in. Combining a JAK inhibitor plus something that hits a different pathway for better responses. For example, the beta inhibitor, pelabresib, when combined with ruxolitinib, doubles the spleen volume response rates. So if 35% of people have a spleen volume reduction on ruxolitinib, with the combination, we expect almost 70% of patients to have a spleen volume reduction, which is pretty impressive.
It is.
And there is an ongoing phase 3 trial, and we hope to get long-term data from that soon to see if these responses are durable, if there's a survival advantage or some other positive benefit. I already mentioned the targeting of calreticulin protein. This mutant calreticulin protein being outside the cell is amenable to targets. There is a monoclonal antibody study that's ongoing, as well as a bispecific antibody study that's ongoing, as well as CAR T cells studies that are launching, which is very, very exciting.
It sure is.
And the other kind of big story in MPNs is targeting hepcidin. I already alluded to that when talking about the JAK inhibitors, but we're doing the opposite in PV. We're actually trying to increase hepcidin levels or effective levels of hepcidin to lower red cell production. So it's kind of cool that in one set of diseases, we're taking a pathway, manipulating in 2 different ways to get 2 different effects, which is just a really cool story.
It is. For the practitioner in the community and elsewhere, what are some of the complications of the diseases that you see, but also of the therapies? And in particular, I'd be interested in your experience with the JAK2 inhibitors.
Yeah. Well, I think that's an important question. There's no such thing as a free lunch, right? And every action has a reaction, and we got to be careful of side effects. Certainly within the disease itself, the common things we think about are fatigue, night sweats, itchy skin, splenomegaly, and spleen-related symptoms like early satiety. And we really kind of focus in on our patients every visit. asking those questions about those symptoms to really take an inventory of how they're feeling. The other kind of complications that we're always worried about is progression to accelerated or blast phase, because once the lid gets off those blasts and that thing is shooting off to acute leukemia, it's incredibly difficult to control. So those are things that we're monitoring quite closely. In terms of therapy, specifically with the JAK inhibitors, there are a couple of things we always watch out for. With ruxolitinib and fedratinib, actually all of the JAK inhibitors, it can cause myelosuppression. So you already have a patient whose bone marrow isn't functioning very well. You add a JAK inhibitor on top of it, you're blocking that normal signal to make blood cells. You can expect some cytopenias in patients. And so that is often a major limiter of the therapy. There are some unique ones with each of the different JAK inhibitors. With ruxolitinib, we often talk about the risk of non-melanoma skin cancers and the risk of developing shingles, as well as weight gain and cholesterol levels going up. With pacritinib, we talk about QTc prolongation, as well as with pacritinib and fedratinib, GI toxicity due to the FLT3 inhibition, nausea and diarrhea potentially. With fedratinib, there is a black box warning for Wernicke's encephalopathy. There was one confirmed case during the development of fedratinib. There were some other suspected cases, but one was confirmed for sure. And fortunately, when that patient did get thiamine replacement, their Wernicke's resolved. So we always check thiamine levels before and during treatment. I often just give my patients thiamine supplements to take while they're taking the fedratinib. Momelotinib can cause some mild GI toxicity during the first couple of cycles, but that usually resolves pretty quickly and is not a limiting factor for that medication. But it can also cause, even though we talk about it treating anemia, it can cause thrombocytopenia and some degree anemia we want to keep in mind. And so really those are kind of the main side effects that we talk about when discussing JAK inhibitors.
What are resources that you would recommend for patients who are taking this journey?
Yeah. So there are a lot of great resources out there for patients. One resource I often steer people to is the MPN Education Advocacy International Group. They're a fantastic group. They do a lot of online webinars for patients. They do in-person seminars for patients as well, have a lot of great resources on their website, and also advocate for patients with MPNs. MPN Research Foundation has some good information on their website. The NCCN, the National Comprehensive Cancer Network, has a patient's guidelines. So where they take the guidelines for doctors, kind of reformulate it and write it down for patients. It's 70 some odd pages long, so it's a lot of information, but it's very good. It's vetted by the panel, a high quality resource for patients. There is the NCI PDQ for patients as well, which I think is a good resource. So a couple more resources out there. There's a really large Facebook group that has thousands of MPN patients in it. It's actually run by a former patient of mine. Really fantastic group that people find a sense of community. And then lastly, LLS, right? So LLS not only focuses on MPNs, but the kind of the broader lymphoma and leukemia world in general, but has a lot of great information for patients. Holds seminars as well. I know I've spoken at a couple in-person group meetings for LLS, and it's always been a fantastic experience.
Thank you. I did want to ask you, because, it's nice to have some data in there, and you're the perfect person for it. What can you tell us about the simplified trials, the momentum trial? Again, things that most of us in general practice probably have not gotten into that depth. So I'd love to learn about it.
Yeah, so it's kind of an interesting story because momelotinib was under development for so long. So what is it, 10-ish years ago, the Simplify trials were launched. 2 prospective randomized phase 3 trials, Simplify 1 being the frontline setting, Simplify 2 being the second-line setting after initial treatment with ruxolitinib. Simplify 1 was the classic drug A versus drug B, momelotinib versus ruxolitinib. And what we saw was that the spleen volume response rates for momelotinib was not inferior, so it was similar to ruxolitinib in that trial, but the symptom response rate wasn't as good with momelotinib compared to ruxolitinib. But what we saw is that there were many more patients who were transfusion independent on momelotinib compared to ruxolitinib. So if we're looking about week 24, 60 some odd percent of patients on momelotinib were transfusion independent, and only 40 some odd percent of patients on ruxolitinib were transfusion independent. In Simplify 2, we saw that momelotinib versus best available therapy wasn't significantly better at shrinking spleens. And that's probably because there was no washout period. So people were on Jakafi, or ruxolitinib, they stopped their ruxolitinib one day, start the momelotinib the next day, and the spleen never got back to baseline. It was better at treating symptoms than best available therapy and was much better at transfusion independence at week 24 compared to best available therapy. So all this came together and said, gee, we should really focus on anemia because that's very consistent in all these studies. And that prompted a phase 2 trial that was led by Dr. Stephen O that included 41 patients who were transfusion dependent. Over 40% of those patients became transfusion independent on momelotinib. And we got all the correlates showing that, yep, we can lower hepcidin levels, and that's the mechanism action. And that then was expanded into the MOMENTUM study, a prospective randomized trial comparing momelotinib versus danazol in patients who had previous exposure to ruxolitinib who were also anemic and symptomatic. And as we expect, momelotinib was better than danazol at treating spleens and symptoms. Danazol doesn't do anything for those.
Right.
But it was not inferior to danazol at treating anemia and transfusion independence rates. So it kind of really cements in our mind that momelotinib is good at shrinking spleens, pretty good at treating symptoms, and also has this anemia benefit.
Yeah, which certainly makes for a better lifestyle for patients.
Yeah, absolutely.
And we've been delighted to be joined by Dr. Aaron Gertz, who's an associate professor of medicine at the Cleveland Clinic, Lerner College of Medicine at Case Western. Aaron, thanks for being with us.
Hey, Dr. Miller, it's been an absolute blast. I'm glad you share my enthusiasm for the MPNs and looking forward to speaking again sometime.
Would love to. This is Dr. Ken Miller. I want to thank all of you for listening to this really terrific and informative episode on a topic that I find is fascinating, which is myeloproliferative neoplasms. For a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, including a fact sheet on MPNs, visit lls.org/CE. And for any questions or to refer a patient to LLS, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources that are available in English and Spanish. LLS also provides other resources for patients, survivors, and their families, and that can be found at lls.org/support. I encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. And if you have suggestions for future episodes, please click the feedback button on this episode page. We look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the LLS podcast series for professionals. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archives section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with LLS by following us on Twitter at LLSUSA and on Facebook at the Leukemia and Lymphoma Society, and access our professional continuing education activities by visiting lls.org/CE. Let's keep the conversation going. Until next time.